If you want to learn how to build a full treatment plan for cystic fibrosis patient and how to manage the recurrent pulmonary infection and choose the right antibiotic, according to the most updated reference, you have found the right video. But before, I suggest to watch the previous video about cystic fibrosis pathophysiology and the complication for better understanding. Now, prepare your notebook and this started with me. I am Asil Qda, clinical pharmacist. Firstly, I'm gonna represent a real case from the practice and we will build a full care plan together and solve each problem that patient have. So, patient name is Sarah, 7 years old and her height is 53 centimeters. Her weight, kilogram. Her vaccine is up to date and her creatinine clearance is normal. It's very important to note something here, which is her height and weight. It's less than average of her age and gender. That means there is a problem in the growth, and that's expected because the nature of the cystic fibrosis, which include enzyme pancreatic insufficiency and malnutrition. Now, what about history of present illness? 7 years and 10 months old female full-term, non-case of cystic fibrosis, diagnosed at age of 1 year, had a multiple hospitalization due to recurrent pulmonary exacerbation, came to the emergency room complained from shortness of breath, productive cough, and abdominal pain. Her last sputum culture in the previous hospitalization saw Pseudomonas aeruginosa colonization. These symptoms tell us that patient have a pulmonary infection, and the result of last sputum culture is very important when planning for the antibiotic you will choose. Another important information about the case that she has allergy of imipenem-cilastatin and ceftazidime. So the acute problem here is cystic fibrosis, pulmonary exacerbation, and abdominal pain, and chronic problem, which is cystic fibrosis and all the complication, and that patient weight and height less than average of her age and gender. So let's fix the first problem, which is cystic fibrosis, pulmonary exacerbation. The treatment of pulmonary exacerbation, of course, antibiotics. What are our options? We have oral antibiotic therapy, intravenous antibiotic therapy, and inhaled antibiotic therapy. But what about antibiotic coverage? The antibiotic coverage, based on periodic culture and sensitivity data, typically covering all organisms identified during the preceding year. Every cystic fibrosis patient have to do culture every hospital visit, and the result should be recorded. What if no culture data are available? Here, we depend on the empirical antibiotic that should cover the most likely organism for the patient's age group. As you see here, bacterial pathogens are often acquired in age-dependent sequence. In early infection, the most suspected infection is caused by MSSA and MRSA and non-typable H. influenza. In the disease, we should expect more danger bacteria like Asmaltophilia, Borchedieria specia, and others. And the most important information that Pseudomonas aeruginosa infection is the most significant cystic fibrosis pathogen among all age group. It's important to cover Pseudomonas aeruginosa. Now, what about the formulation of antibiotic? Is it oral, inhaled, or IV? The choice depends on the severity. If recent onset or mild, you should choose oral with or without inhaled. Here, the duration of therapy will be 10 to 14 days. If it's severe or recurrent or failed outpatient therapy, here you should use IV and the duration will be 10 to 21 days. Mainly in the practice, we use oral fluoroquinolone for Pseudomonas aeruginosa coverage. Cystic fibrosis disease is one of the exceptional cases that we give pediatric fluoroquinolone. Otherwise, it's not recommended for pediatric. And for Asmaltophilia bacteria, you can use oral trimethoprim sulfamethoxazole or minocycline. So, in outpatient treatment for mild infection, we used oral antibiotic. What about severe exacerbation or when failed outpatient therapy? Here, the treatment will be inpatient in the hospital. We will use IV antibiotic. We should use 2 IV antibiotic with 2 different mechanisms of action. It's recommended to use 1 antipseudomonal beta-lactam plus 1 aminoglycoside. There's some recommendation can help you in choosing process. Firstly, cephalosporin tend to be better tolerated and offer the benefit of less frequent administration. For extended spectrum penicillin allergy cases, you can use azithromycin. Recommended third meropenem for organism resistant to all other antibiotics to minimize development of resistance in the carbapenem drug class. And you can substitute oral fluoroquinolone instead of IV aminoglycoside based on sensitivity data. Or if the patient have a renal dysfunction and or ototoxicity, in this case you can't use aminoglycoside, so you can use oral fluoroquinolone instead. And colistin IV and chloramphenicol IV are reserved for life-threatening or highly resistant infection. And in patient treatment for MRSA, you can use IV vancomycin or oral agent cover MRSA. Cystic fibrosis patients have larger volume distribution for many antibiotics due to an increased ratio of lean body mass to total body mass and lower fat store. And cystic fibrosis patients also have enhanced total body clearance. These factors affect the doses of the antibiotic that used in cystic fibrosis patients. Here, selected antibiotic dosing in cystic fibrosis, IV, oral or inhaled. These are our options. So, return to our case. As the case here, a recurrent infection, so the treatment will be IV antibiotic. Before thinking about the antibiotic, you should take a sample for a new culture to rule out if there is a new bacteria caused the infection. Then you will think about empirical treatment that cover the most suspected bacteria that may cause this infection. Based on the record of the last hospitalization for this patient, we should cover Pseudomonas aeruginosa. So, you need 2 antibiotics with 2 different mechanisms of action. The patient here have imipenem/cilastatin and ceftazidime allergy. So, in this case, you can choose a drug from carbapenem, such as meropenem. And the second drug may be from aminoglycoside group like gentamicin. So, for this patient, gentamicin and meropenem may be a useful combination. And the treatment duration will be from 10 to 21 days, depend on the patient progress in the hospital. For gentamicin, recent studies state that aminoglycoside 1 daily dose better than multiple dose in cystic fibrosis patient. So, is that enough for acute exacerbation? The answer is no, since the main problem in cystic fibrosis is the thick mucus, so we should help patient to clear the airway. So, airway clearance therapy is necessary routine for all cystic fibrosis patients to clear secretions and control infection even at the diagnosis prior to becoming symptomatic. So, cystic fibrosis patients have to commit to special routine for pulmonary health. It consists of chest physiotherapy, which is percussion, and postural drainage. Patient may also be taught to autogenic drainage, which consists of deep breathing exercise followed by forced cough. That will help patient to get rid of mucus. Patient should do chest physiotherapy 1 to 2 times daily for maintenance care. And during acute exacerbation and infection, patient should do chest physiotherapy 3 to 4 times, and more is better. And since the mucus is thick, patient will need a mucolytic agent in their routine. For a mucolytic agent, we have 3 options. First option, which is hypertonic saline. The mechanism of action of hypertonic saline depends on the osmotic effect. There is a many strengths like 2.5, 3, 5, and 7, even 9%. The dose in cystic fibrosis is formal nebulized 1 to 4 times per day. Actually, we use it with chest physiotherapy. So in the maintenance use, patient can use hypertonic saline 1 to 2 times per day, and in the exacerbation, we will increase the number of use to 3 to 4 times per day. And more is better for sure. But you should note the main side effect of hypertonic saline, which may cause bronchospasm. So it's better to proceed by bronchodilator. There are 2 other options can use, like N-acetylcysteine, which split disulfide bond in mucoproteins and lower the mucus viscosity. N-acetylcysteine also cause bronchospasm and need proceed by bronchodilator. And it's not used very much in practice because it has unpleasant odor and taste. The last choice, which is the better choice, which is Dornase alpha, but it's the last choice because it's very expensive and it's not available in many countries. So as a summary, for patient routine, patient should use bronchodilator like albuterol, then mucolytic agent, then chest physiotherapy 1 to 2 times in the maintenance care, the 3 to 4 times in the exacerbation. Besides airway clearance routine, anti-inflammatory medication have an important role in the maintenance treatment for pulmonary health in cystic fibrosis patients. One of the drugs that used for its anti-inflammatory effect is azithromycin. Azithromycin improves overall lung function and reduce exacerbation in patients colonized with the Pseudomonas, and even those without Pseudomonas, it can reduce the exacerbation. The dose of azithromycin in cystic fibrosis patient depend on the weight. If the patient less than 39 kg, the dose will be 250 mg. And if the weight is more than 40 kg, the dose will be 500 mg. Both doses are taken 3 times per week due to its long tissue half-life. It's very important to know that patients should have screening acid-fast bacillus sputum culture prior to initiation and then every 6 to 12 months while taking azithromycin. And that because the isolation of non-tuberculosis mycobacteria is a contraindication to chronic azithromycin therapy. Some studies shows that azithromycin at a concentration achievable during therapeutic dose can block the intracellular killing of mycobacteria within macrophage and lead to chronic non-tuberculosis mycobacteria infection in mouse model. So when the isolation non-tuberculosis in the patient, you should stop azithromycin immediately. At the end, we will talk about the role of inhaled antibiotic. Chronic or rotating inhaled antibiotic maintenance therapy may be used to suppress Pseudomonas aeruginosa colonization in cystic fibrosis patients of all ages. Available inhaled antibiotic that can be used topramycin, azithromycin, and nebulized colistin. Inhaled topramycin is the best. It's typically administered to a patient more than 6 years of old. It's given in alternating 28-day cycle followed by a 28-day washed-out period, almost every other month. The second option is azithromycin, and the last option is nebulized colistin. Be careful that nebulized colistin should be pre-treatment with albuterol, and it's used with topramycin resistant strain or intolerance to inhaled topramycin or azithromycin. It's very important to know that inhaled antibiotics are typically stopped during acute exacerbation, which requiring IV therapy because drug delivery is reduced with increased sputum production in case of exacerbation, and the concomitant use of IV aminoglycoside may increase the risk of toxicity. So, while treat the exacerbation, you should hold the inhaled antibiotic. And now you can stop the video and try to build the treatment plan for acute exacerbation and for chronic maintenance therapy for the lung in cystic fibrosis. Now let's check your answers. Treatment plan for our case for pulmonary exacerbation. We add empirical treatment. We have choose gentamicin and meropenem. Then you should add airway clearance routine for exacerbation, which is albuterol, then hypertonic saline, this chest physiotherapy 4 times per day, and that's for acute exacerbation. After the treatment of the exacerbation, you should add for maintenance therapy, airway clearance routine, the same as in the exacerbation or in the acute exacerbation, but airway clearance routine will be 1 to 2 times per day, maybe in the morning and the evening. Maintenance pulmonary health, you can add azithromycin 3 times per week, and you can add inhaled topramycin 300 mg nebulized twice daily, 28-day cycle period followed by 28 days washed out period to reduce the resistance. And that's the full regimen for pulmonary health in cystic fibrosis patient. Eventually, I hope this covered pulmonary exacerbation in cystic fibrosis. If you have any question, leave it in the comment and I will respond as soon as possible. In the next video, we will talk about the treatment of pancreatic insufficiency in cystic fibrosis. Till that, I hope you will be fine. Thank you for watching.